Mwami balakulorasa esaino buli mundu alinga yangakaya
bukote bwa bulindalo khukhwama mukholo chefwe
nakhubola nandi kimima kyomukhase kili mungubo ta ne khali mayula chakho kamaseyaya mumoni mwaniyala wabona chizaya chaka khucha kumwikhanga kwe chimoyo kuku maifukila soli we wakhola urgena kimyaka kyachi
namu yesike minile sanende bunama buli samu khamini sikati bunama akenda hata ni atecho khabao lakini yesiyo sina busa
bukuli na bukulani busomi nende bukhangarani
senegandi shipindi kino ndichokhulu chomulecheresi shiyananga obuyango bulayi sana khubasakhulu nende abandu bechikhaye okhurula saa 5 okhula saa 6 tumushitsimi ndechesinja abandu ngale bakhoshile khumenya
West TV, tazama ilivyo.
Good morning, dear viewer. You are so welcome on West TV. I'm so excited to join with you here today to have a conversation in healthcare. You see, healthcare is wide, very big, and we don't want to get lost in the wideness. We'll go slow and just understand each other. KMTC is the largest supplier of healthcare workforce in the whole country. And I understand we have an agreement where KMTC is supplying workforce to the international market. But that is just a section of what we're going to talk about. But we just want to look at trends, what's happening in the healthcare sector from the non-political side. Because the political side, we're talking about SHA, SHIF, and a bit of those, delivery of healthcare. But as we're looking at the pain, is when a patient comes to the hospital, there is that pain is feeling. That's what matters to this guy, just removing the pain. So we want to dwell there. I want to concentrate on elimination of this pain from the patient. And what's happening out there, especially this region, Western Kenya. We have what is treated mostly and what is not, what we only hear about, and how life goes on. So thank you for joining West TV. The morning scope, we're talking about trends in healthcare. With my guest today, we will be looking at it widely, but before my guest comes, I just want to congratulate you. This show is streaming live on YouTube. Please, when you're there, leave a comment, share, and subscribe. You can leave me a comment on West TV _Kenya, that's on X. On my Twitter handle is at Mr. Kitui. I'll be able to incorporate your thoughts into this conversation. On behalf of the director of the show, my name is CKS. Thank you so much. Madam Karibu.
Thank you so much.
How is life?
Life is good.
Yes.
And thank you for having me.
You see,
morning.
You guys carry needles, yes. And I fear needles. I don't like them. By any chance, do you carry them?
No, I haven't carried.
Good, so you can do the show. Because if I carried them, I could have just excused myself to go and hide.
No. And it's not bad. It's not that bad.
Okay.
I know what you're thinking about. We have better ways of injecting nowadays.
Okay.
It's not the one that leaves a hole.
Let's begin the show.
Okay.
Before you even tell us your name, Victoria Koi is running KMTC Bungoma, one of the KMTCs in Kenya, but you'll tell us a bit of that. The proverb is hands wash each other.
Yes.
How do you understand that?
Yes. Yeah, I mean, basically that is what we always do. You cannot run alone. You cannot do anything without another person. So as KMTC, we actually depend on the community. It is the community that helps us to be who we are. And that is how all our programs, our institutions are community-based.
Okay.
If that makes sense.
A lot.
All right.
You see, proverbs are, they don't have one rule, one way of elaborating on them. Whichever way you talk about it is all right. So thank you.
Welcome. Yes.
Just tell us a bit of your name and your strength. You are a guy from the radiology department.
Yes.
Yeah.
So my name is Victoria Koi. I'm a mother and a professional, proud to be a KMTC alumni, trained in radiography and imaging from KMTC Nairobi, the first and only.
Okay.
Yes, before we came to other campuses. Nairobi is like the mother of it all. I've been in the profession for a while and gone through the stages of education. I did my diploma, higher diploma in KMTC. I went to University of Johannesburg in South Africa for my bachelor's degree. Came back, went to Kenyatta University for my master's in health management.
Okay.
Before becoming the principal of KMTC.
Whoa, that's quite a journey. You see, the KMTC is from the outside. No, you say it community-based.
Yes.
You make us understand how community that is.
Yes.
But you see, from where I sit, KMTC is an exclusive club. It's for them. When you pass by the KMTC gate, you see that is KMTC and that's it. No interaction with us. The time we meet with you guys is at the hospital. So don't get sick, you'll never interact with the KMTC. Why is that?
You know, it's interesting. I think that is a myth that we need to change our thinking. Remember, if I give an example of KMTC Bungoma, it's actually a community initiative that started in 2011, where the community called out for KMTC to have a KMTC, a training institution in Bungoma. And that is how KMTC came in. We only do programs, but everything else is done from the community.
Okay.
The land belongs to the community until it is given to KMTC once we develop it. And that is how it is. In all the campuses you hear, it is actually community initiated.
Okay.
Yes. So maybe just to say it is open to the community.
So,
and I want to welcome
all
the people in the community to own it. Yes. It is theirs. Yes.
Before we talk about the nurse or the person who is managing primary health care, let's look at the institution. In brief, what's the mandate?
Yeah. So the mandate of KMTC, very briefly, is to train healthcare workforce for the nation and globally. And when you're talking about the workforce, we're not only focusing on nursing, because that is what is known.
Okay.
We have 18 programs that are all focused in healthcare, taking care of the community. We have nursing, we have clinical medicine, we have physiotherapy, we have radiography, of course, which is my field. We have health records, we have many others.
Okay.
And I leave you the brochure so that you can also disseminate. And so all these programs are focused on helping the health sector. It is initiated again from the community. What is happening? What are some of the gaps that we get from research that we do to be able to get a course that actually meets that gap?
Okay.
Yeah.
The issue that comes into my mind is managing the patient. Management of patient is a preserve of a nurse. We may have other support systems, like you talked about radiography. If this patient needs to go for scans,
that is the diagnostic.
Yeah. Yes. If we have lab technician. If needs medicine, you go to the pharmacy. But then this patient is in the hands of a nurse.
Exactly.
Okay. So it's a nurse we must blame if anything goes wrong with this patient. And the patient came here with headache. One particular place here, it's the nurse to do the miracle. Just in brief, what is it that you tell these guys? What is it that you tell these nurses that makes them so perfect at handling this patient?
So maybe again, just to correct a little bit, you don't put all the blame on the nurse.
Okay.
Because the diagnosis of a patient starts from the time they see a doctor, they do the labs, the radiology and all that, and the prescription that is supposed to be given to this patient.
Okay.
Then the nurse now takes care of that.
Okay.
So if there's any issue that didn't go well in line before it go to the nurse,
yes,
then it will be a problem all through.
Okay.
So it cannot be for the nurse alone. So don't put it that way. However, we try to train our nurses to understand the trends of the diseases, and that is how it's again community based. And we try to do a variety of what is there in the community in terms of, for example, we have community health nursing, which goes more into the community, understanding the needs, the diagnosis, what ails the community.
Yes.
You know, in Western, for example, we have a lot of malaria. It's surprising, I don't know if you know, that we still have jiggers.
Of course, we do have that.
So, I mean, those are some of the things that are picked and then, you know, brought back. And you make sure that they understand how it is diagnosed and how it's treated. So that by the time they get the patient in hospital, they already know what to do.
So these community nurses are in the community. Of course, they are trained here, but they are in the community. That's where they manage these patients. They understand these patients and manage them from there.
Exactly.
My big question now comes in. You see, the human side. I've interacted with some nurses who are rogue. How different are they from community nurses? Or rogue nurses are in the community?
We don't train nurses to be rogues.
Okay.
So that is actually not okay to call them rogues. However, I mean, in life, apart from being a professional, you're also a human being, as you say.
Okay.
And at times things happen to people and they have to be on duty. And maybe there's a misunderstanding. But it's not about being a rogue. Our nurses are trained to actually have the human part. And we say this is from the beginning. We train them because when you take a health professional course, it means you have to know that you're dealing with human life. You have to be compassionate. You have to be professional, you know, so you cannot go beyond that scope. But you come back to be a human being, then you are supposed to counsel someone, you know, who also, who you relate with what they are going through. You get, so at times that would interfere, but basically we give them skills competent enough for them to be able to handle patients at whatever level.
And then these nurses are oversupplied in one department and less supplied in other department. Can you talk about distribution? You talked about a few courses that you guys offer, right? When we interact with them, when we go to a hospital, we don't understand from outside here which one is doing what. But then once we see them in that uniform, we see these are nurses. And in the rural there, we call them doctors. They look the same. Now, can you share to us how the distribution at the training level? Because then, before we got health records, we have clinical nurses, then we have clinical officers, we have lab guys. So how are they distributed? Especially, is it different classes? One class might have 100, another one have 20. So we don't blame them for being 20 and the other one 100. Or how are they distributed at the training level?
So at the training level, again, remember we don't work alone. And you said it well. The hand washes the other hand.
Okay.
We deal with the council, the professional bodies, and they are the ones who actually direct us in how they want it done. For example, training of a nurse, we can only do 50 a class. 50 nurses per intake.
Okay.
Yeah. So if we're having a match class, you cannot take 100 nurses. For Bungoma KMTC, you can only do 50.
Okay.
And that's actually what informs also that if we want to have enough nurses supplied in Kenya, then we need to have more campuses that are offering nursing courses. Clinical medicine is the same, also directed by their professional body. So you can only also have 50 in a class.
So this 50 you are talking about includes health records?
No. That is just for each.
Oh, okay.
Yeah.
For each of those services.
For each of the courses that we offer that have accredited professional bodies.
Yes.
They actually give us the numbers that we can train in a year. Yes.
Okay.
So we can't go beyond those numbers. And of course, being the professional bodies, then they understand the trend and the scope, so that we're not also oversupplying or undersupplying.
But then we have undersupplied because nurses are not enough.
And that is why we are trying to make sure that we expand the programs, to make sure that we take them closest to the people so that they can be able, so that it's accessible.
Yes.
And of course our courses are affordable if you compare to any other institution.
At the service delivery level, the biggest employer of healthcare workers is the county.
Yes.
Do you think we have
yes.
Do you have the sufficient supply of workers in the sector or not? And if there is a deficit, how much is the deficit?
I wouldn't go that. You said we're not doing political, eh?
No, it's not
but
political.
Yes, we know that we don't have enough. Actually, there's a shortage in every of the hospitals that we have. There's a shortage of healthcare providers, workers. So let me not say nurses. Of course, nurses have more demand in terms of even the work that they do, from the community level all the way to the national level.
Yes.
So yes, we have that. And because of that, then we need to be privy to the fact that if we don't continue training and one day these guys are employed, then we might go back to the drawing board and wonder where we get the workforce. Because
you see, it's the market that demands the supply. As in, it dictates how the supply should be. If there is shortage already, why do we limit the intake numbers? Why don't we increase the numbers to meet the demand, given that you're also training for the international market? Yeah, true. I think that is something that is going on. It is a conversation that our board and CEO are having with the professional bodies in terms of just understanding the scope and how best we can be able to work together. Yeah, so again, that is underway. It's a discussion that is ongoing. Okay. Yes, and we have more programs. We have more campuses actually being accredited to do the courses. The nursing, clinical medicine. Yes.
Yeah.
How do you talk to these guys when they come in? No, we go in because we come from a line of nurses, referrals. And then apart from referrals, we also have desire. I want to go and work in a hospital. How do you manage that vis-a-vis the demand on the market? Because if the demand requires that we want more health record workers, then those who have come in are not taking that course because it doesn't have money. How do you seal that gap? Yeah, so as KMTC, what we have done is one, to make sure that we are connected to the community. Okay. And we do a lot of mobilization and sensitization of the community in terms of the programs that we offer. And maybe just to, because I have this opportunity to tell my Western people that it is from
school that we actually are able to get these people to focus on what they want to do. For example, we have the science clubs in schools, and they used to visit hospitals. And so those are people that we want to reach out to so that they start understanding what it is in healthcare, to understand the programs that we have, so that you don't come out because of a referral or because you had somebody saying if you do nursing, you'll go to the US.
Australia.
Australia and UK, you know.
I love Australia.
But you need to
if I were a nurse, I'd go to Australia, by the way.
All right. You need to have the heart to be able to actually take care of a patient. And that you can start when you're still way in school by, you know, engaging in camps, by being in the science club and going out into the community and start serving the community as early as when you're still in school.
Okay.
Then that way, then we have you actually understand which direction you want to take. What we have also done is try to talk about the other programs that we have, so that you give them. There's no program that is bad in KMTC, by the way, in healthcare, and it all has money, and it grows. The older it is, the better.
The better, okay.
So we actually talk to the community about our programs. We try to go into schools, into barazas, to talk about our programs, so that somebody doesn't come knowing it's only nursing. When they get to our desk, all KMTCs have desk officers. We are the first people who actually interact with the people who come to inquire. And so when they come to inquire, then they're actually told about all the other programs before they think about nursing. So there are people who have come wanting to do nursing, but when we tell them about the other programs, they actually pick.
Because it looks more like it meets their passion.
Exactly.
In Western Kenya, you talked about malaria. What other ailments are prevalent?
We have diabetes, we have hypertension, most of it, and of course the aging group is also becoming an issue, and that is why, and of course mental health issues also.
When we talk about aging, the population's bulk of the population is past 80, right? Some of them even get affected in their 70s with old age issues. What do these people really need?
So they need care in terms of someone who would be able to understand at that primary level. For example, a nurse will be able to diagnose at that primary level. Apart from aging, the person could be having hypertension. They need to know how to handle that and how to make sure that they have their medications and how to take them. They need physiotherapy. They need occupational therapy, because again, when you sit for a long time without movement, it becomes an issue. And the movement is limited because of the age. So then again, you have to get someone to support.
Help you walk around.
Exactly. And that's why when you see now, we are going more towards having the physical courses, physical part of courses, the physiotherapy, the occupational therapy, the orthopedic technologies, so that they can be able to help the community. We also have community health workers or assistants who would actually do just a little bit less than what a nurse would do to be able to support these people at the community level, at that small unit, at that house. We have had a lot of cases where we have people, there's a lot of demand now of having someone to take care of your old parent.
So do you do that as an institution, or you only train them and they're deployed from elsewhere, like from the hospitals?
We train them.
You only
for
train
the community,
them for the community.
Yes.
So where they're deployed from is not your control.
No, it's not our control.
And then we have strange guys called nurse assistants or nurse aides. What makes them strange?
It is not strange. Actually, that is again a demand, just because it is something that needs to be I think it's an ongoing thing that needs to be, we're trying to make sure that it happens in the right way, in the legal way.
Okay.
The nurse assistant supports just what I'm saying, that you are giving medication to this old person who is almost going senile, who is going to support them at that level.
So are they trained? Is it a course or it's just...
So there has been, it has just been something that has not been happening officially, but KMTC is taking it up now, so that we are able to actually give the correct information to these people, or training to these people, so that when they go out, they have the right skill. Yeah, they are not doing the work of a nurse. They are only assisting. That's the way you can tell someone, give this mzee a tablet once, 3 times a day. And this person does not understand, and the mzee also does not understand. So what we need to do is to have someone who understands that part of it, that they can be able to take care of these people at the lowest level in the household units.
You eat before you take the drug.
Exactly.
And you take this amount of drugs
at this time.
At this time.
Exactly.
We talked about healthcare, mental health. Mental health is big now.
It is.
It has categories. Some of them are like me. You can notice until you actually put me to test. At what stage are health workers supposed to intervene and interact with this patient and manage them?
Again, as KMTC, we actually advocate for prevention.
Prevention,
It is better than curing. And therefore we look out for people to do, we actually say, let people go for counseling. The little that you think is disturbing you, talk to somebody, talk to a professional. We have health counseling course now.
You have that course?
Yes, it is in Mathare, KMTC. We're training, and many other campuses are coming up with it, so that we have people who can actually assist. At times you can talk to someone, I can talk to you, and without you knowing, I actually realize that there's something much more that meets the eye. So you need to be referred to a counselor so that they support you before it goes overboard. Yeah, so prevention always better than cure.
So that's generally how KMTC supports delivery of healthcare.
Yes.
Any other way you guys support delivery of healthcare to the community?
So apart from giving the enough workforce, we also look at the demands that they have in the changing trends, as you're saying. Initially, we didn't have a lot of mental health. Now we have. So we actually we get a course that can be able to support that. We also support in terms of, for example, now we know that there's a lot of demand for nurses to go out, and they have to do some examination before they go. And so KMTC has started, we're actually doing the nurses who graduate and they have an intention of going out to the US. There is the NCLEX examination that they have to do. Now we offer it in Mathare, which they can do as even they wait for their graduation, and then they start processing. So again, we look at what are the gaps that are out there that we can be able to support our graduates and our community.
Without going into politics, from graduation to deployment, how many years in between?
No. Actually, that purely depends. Purely depends. There are courses where by the time somebody is graduating, they are all gone.
Okay.
Exactly. There are those who maybe want to go back into furthering their studies, which again we offer. They can come back for higher diplomas, before they can proceed. A year is more than enough for somebody.
Okay. I've worked in the healthcare sector myself. In my other life, I was running a hospital, and I realized that medical officers who are graduates from university have a certain level of entrance to the patient, but lower levels are handled by clinical officers. So guys in the private sector, the private health facilities, including public of course, but then the private have gone large in employing clinical officers. Of course, let me tell you the secret, and don't reveal it to me. Okay, I've said it. Okay, I've said it. They make more money than medical doctors, okay, because they will see more patients and they have this human side, okay. In fact, medical doctors, most are a bit harsh than physicians, they're called specialists. Specialists are very friendly, very nice people. Clinical officers are very good, very nice people. So they make more money for institutions. Is it in the training or it's in the person?
I think it's both, but let me again say, this comparison is not okay. I said, you know, there are individuals who have their own issues, and maybe that one rotten potato then makes the whole
yes.
rotten. But clinical officers are trained for that primary health care all the way, okay? And of course, the way I said, our training is skill-based, competency-based, and community-based. So that interaction with the patient is more, all the way from the time they get into the college to the time they come out. So the community is not strange to them. You know, so maybe that is the part that you find it a little bit different.
Okay, I've said it. You can show me, but please don't. There are goals, okay? Like this region, we have 4 counties in Western and Trans Nzoia, which is 5 counties, which is actually Western Kenya. We interact a lot. We share a lot. There are goals in this region. The county governments in this region have goals to eliminate or to support healthcare to a certain level by a certain period. Do you guys work in collaboration? Because when they say we need to eliminate or to take care of or to manage these kind of sicknesses or manage patients in this way, build hospitals here, equip hospitals here, do this, do they work in collaboration with you guys? Because when they set up a hospital, for example, it means you guys need to supply the workforce. And you have a collaboration like that with the government on the side of delivery of healthcare workers.
Yeah, so of course we work very closely. We work very, very closely with the counties, the government.
Okay.
To start a course does not just come from KMTC. It's actually stakeholders.
Okay.
Both private and public. You know, and the community. So that if Western has, we actually structure our courses based more on what the community needs.
Okay, okay.
Yeah. And so like for Western, I can see you have included Kitale.
Well, Kitale is so much Western. In fact, the name is Luya, so don't worry.
Yeah, so like for Western, we have, if we do the 5 counties, including Kitale,
yes,
we have MTCs that are providing different courses that would meet the demand for the Western part.
Okay.
We have for Kakamega County, for example, we have 4 campuses. We have Lugari, and Lugari mostly has CHA, which is for the community. We have Navaholo coming up. We have Shianda. We have Kakamega campus, which has all these courses. And if you look at it overall, we actually are almost getting to the 18 that are majorly in Nairobi. Then we have Bungoma County, where we have 3 campuses, Webuye, Chwele, and Bungoma, KMTC. Then we have Busia, that has 2. We have Busia, KMTC, and we have Teso.
Teso, okay.
And then we have Kitale, MTC, and we can extend it to Kapenguria.
Okay.
Yes.
If we want, because we can. Okay. Now, there is this issue about when time progresses. This is 2025, okay? 2027, you have 100 years, huh?
Yes.
Now, 1927, or let's say 1955, This is 2025. There's a different way of delivering healthcare. Those days we could use long needles, large syringe, like 10 liters type of syringes. That has not been there. As in, it's been managed to sizable, very small needles and stuff like that. That is how technology demands. Nowadays, when we progress, also the things we use also change to meet the times. I'm saying that to look at the health records department. Rooms with large files have been eliminated.
True.
You've gone online, you've gone digital. Are you training a health record digitally? Or you do the paperwork, finish, then you send this person to, it's called what, Multimedia University, to go and learn?
Go and learn.
Yes, how to do this, or do you have that course? And if someone would be interested to do health records, but then modern day health records.
Yeah, so, okay, so we have the strategic plans that we use. We just don't operate.
Okay.
And we have the strategic plan 2023-2028, the 5-year strategic plan, which actually now comes out very clearly to give the key areas or the key strategy, the goals that we need to meet.
Okay.
And one of it, we have quality training, and then we have digital transformation.
Okay.
And we have research and innovation and sustainability of the institution. And so when we look at that, then we go back to the curriculum. We update our curriculum between 3 and 5 years, depending on what is happening.
Okay.
So as the trend changes, then we also change our curricula to meet the
what's happening on the market.
Exactly, what is happening. So as we trained initially, health records, and I don't know why you're so interested in health records, but because we are going digital. Because
it's where you begin.
Exactly.
Yeah, they'll give you like a small paper, you go and carry a big file, then you'll end up with a small paper having carried a big file around the hospital.
No, and I think now you have seen a bit of difference even when you go to the health facilities, even government health facilities. They are more digital. Okay, so our graduates are also being trained to do the digital transformation.
Yes.
Then they also do research as students themselves to be able to understand what is happening, what trend we are having, and how they can actually do, because we have innovation. I think you've seen in one of our core values is innovation.
Yes.
Yes. And so they are open to be able to innovate and maybe have devices.
Okay.
We have artificial intelligence, which has to also be part of what we put in our curriculum. Yes.
We have issues to do with where do these health workers end up. Primary destination is hospitals. Is that all?
No, that's not it. Okay. We have hospital, of course, taking the majority. But now we have industries, we have research institutions where all these people work out there in the industry and all that. Most of
such as,
for example, Cambridge, where we have a lot of research going on. Most of our lab people
go there. Okay.
We have manufacturing companies.
Yes.
Pharmaceuticals. Most of our graduates will go there in pharmacy and all. We have the sales, the medical sales people in marketing. Our graduates go out there to
okay. Now, before you continue, these guys who drive around in vans selling drugs,
they have to know what they are selling. Some of them are actually KMTC graduates.
Okay.
Yeah. So they're employed in industries, in manufacturing companies.
So the pressure is not on hospitals to absorb KMTC graduates.
No.
They can also work.
They can
anywhere.
work elsewhere. Yeah.
Manufacturing. There is research. There's marketing. Where else?
Like we have companies that sell medical equipment.
Yes.
They have. That is part of where we take our students.
Okay.
Yeah.
That's very interesting. So, for KMTC to expand its impact, Okay. From where we are at this 2025, with so much impact you guys are delivering, for you to expand your impact to be felt more, where will the institution go? Manufacturing? Or that's wishful thinking?
That is wishful thinking. True. Our mandate is purely training. And all we do the best is to make sure that we actually fill the gap that is being felt in the community. That is how we collaborate. We work very closely with them to understand.
Yes.
So, for example, we have now the SHA and SHIF, we have digital technology, and KMTC has started a course in health insurance.
Okay.
So that when you now walk there to want to get your services, there's somebody who understands about the giving the accreditation, I mean the permission for you to be able to get your work done, the approvals.
And you see that's going to be very nice because, of course, medical covers are managed by medical doctors. And so if you're entering that market, it's going to be interesting. You're going to compete with them and just
No, we already have a class going on. Yeah, the other thing that we have done, which is big, is actually mortuary assistance. Mortuary technologies. We are actually training the mortuary assistant.
And then there are two areas which I would like you to highlight. Injuries. Bones get broken every time. Borders are breaking people's bones every day, and some of those injuries are actually head injuries. What is it that you talked about prevention? What is it that you can talk to the community to just to prevent that kind of injuries? The community is suffering a lot because most bones are broken, and someone is genuinely working and the border crashes them, or someone is using a border to go to work. Prevention, how do we manage that? Then I also want you to talk about physically impaired, people who are living with disabilities. How are you supporting that market?
Wow, thank you for that. I think one, we actually have embarked on a program of training border riders on fast response, first aid, and what you need to do when you get a casualty. Most of the time they're the first people who get where the patient is, or the causing the accident.
Yes.
Okay, how do you handle this person? And that is something that we're doing countrywide in all our KMTCs.
Okay.
KMTC Bungoma will be training on Monday, next week on 17th. We're taking a small group of about 100 to just give them that, so that we hope they can cascade it down to the others, so that they understand. That is just prevention from that point where there's an accident. Even how do you handle that person to move? Because at times the person is not so bad, but how you handle
the movement.
Yes, then
and you see the bleeding is what kills most of them.
Exactly, so causes more harm than good. So that is one of the things that we're doing. For physically impaired and all that, we have courses that we have put together. There are short courses and or long courses. For example, again, Bungoma, we have sign language course. Okay. Yes, so that we have people coming to learn the sign language to be able to actually interact with the community.
Okay.
For our students, they're already doing that. They can be able to support those who come to hospital. We have speech therapy, which is a course that we are running.
Speech therapy?
Yes.
Okay. That doesn't need students only?
No. We need people to be trained in it.
Well, as in, you see, it's not an 8 to 5 class. It's speech therapy. I can enroll, right?
For speech therapy, I think we need to have, it's a course that is running. For sign language, you can come in because it's a short course, and it's not an 8 to 5.
Okay.
It is, so we have short courses, and we have the normal courses that we do 2 years and 3 years. Yes.
With like diploma.
Yes, we have diploma, we have certificates.
Okay.
And we have upgrading. Of course, that is just for continuous professional development.
Okay. Whoa, we need to be ending the show. There are guys who are imagining that when I grow up I'll be a nurse or I'll be a medical officer or a clinical or healthcare worker. What should be what should be the first thing they consider? Just speak to aspiring. Yeah, just talk to those aspiring.
The passion to serve.
Okay.
The passion to serve. And maybe what I would want to also encourage and say, you can never regret being in the healthcare profession, because it gives you a lot of satisfaction, especially when you serve and you see someone, come out of it better. Yeah, when you touch human life, when you're part and parcel of changing how the community's health exists. So I would actually urge that they want, again I said, from school, don't wait until you have finished. Target the subjects that you need, which is the sciences, biology, mathematics, chemistry, physics.
It's called STEM.
The STEM subjects, of course, and then we have the language, which is either English or Swahili.
Yes.
So that comes from all the way. Once you have that, then you are able to actually choose what is your passion in all of the courses that we offer.
Yes.
But bottom line is that it is something that you'll be proud to be part of the health sector in just changing how the community lives. Yes, because it touches on life.
You talked about research. What kind of research do you do? Do you do for your own consumption or for the public consumption?
We have both.
Okay.
Yeah, we also a research institution, so we do both. Research for us to be able to see what is in the gap and how we can fill the gap. Then we also have our students. Before all the students who come to KMTC to do the courses, certificate or diploma, they do a research based on what the course they're taking.
Okay.
So again, it's something that when they go into the community, whatever they do, research or data doesn't lie. So when it comes back, then we can now consume either for ourselves or for the community.
Then there is the exit. You go into a training institution, you are equipped to be a healthcare worker professional, then you exit. So that exit, when guys have finished everything, they're now going home. Maybe you are 80 years old and you were a nurse when you were young. Does it prepare you for that? And are you able to transfer that preparation to people who didn't go through the medical training or what? Because we talked about managing the old, where we tend to struggle with them. Sometimes they're a bit harsh, temperamental, but then when you are dealing with someone who went through and grew old, do you have like those in a club or in an arrangement where they can be able to talk to other elderly who didn't go through medical lifestyle, or who are not workers in the medical sector, but they are elderly and they have issues and they can't cope with these Gen Zs? Or that is another wishful thinking.
That is, it's a good thinking, but what we do is that the encouragement is that when you leave the formal work, then the expectation is to go and work in the community. In the community, the skill doesn't die.
Of course.
Yeah, so that is the skill that you need to be passing.
So wherever you are retiring,
exactly,
you need to make a charmer of the like-minded, the elderly. So you socialize, you associate with them at that level.
Exactly.
Okay. I think I want to give you one more minute just to talk about your parting shot. What would you like to tell the viewers? And maybe you should also add, if someone is so fixed that I want to go and train and go and work in Canada, whether it's the right thing to do, where one works should drive the need to go to an institution to learn, or the delivery of the service as per the passion is what is important.
Yeah, so again, we say where there's a will, there's a way. So we want to give an opportunity to all who are able to want to come and train, to be trained. We actually have courses that we actually take, even D+. We have structured courses. You can have someone get in at D+, you know, so that is not fail, because in the community it's a fail. It's not a fail. Pick up that person who has the lowest grade and allow them to move through the system. Okay, and we have seen heroes who have come from very low to PhD.
Okay.
So where there's a will, there's a way. I would encourage that as many students who want to come to do our courses actually come to understand what it is. KMTC Bungoma and all the other KMTCs, as I said, are open to the community. Come, let's talk, let's advise. We're also going out into the community very soon to talk to the people who would want to hear, so that we are able to have as many people in the community trained.
Okay.
You know, when you train someone in the community, you have trained the whole community.
Okay.
So I would really want to say thank you for the opportunity to come here and to urge that we work together. KMTC is not isolation, is not an island. It is for the community, and so we urge that the community comes to join in.
Okay.
Let's build it.
Whoa.
Yes.
Thank you for the valuable insight. You've actually been very helpful. I'm sure my viewers have enjoyed the conversation. They've been enlightened. Without much ado, I just want to say thank you for watching. Say hi to the fraternity, KMTC fraternity. Tell them as long as they're not carrying needles, I'm okay.
And maybe just to give you one, KMTC is one with many campuses. We're under a board, a CEO, and the management, which sits in Nairobi. So that it's not like KMTC stands alone, KMTC Bungoma stands alone. We actually aligned just one KMTC,
yes,
with many
one CEO,
campuses, one CEO,
and he's very young, by the way.
Very good CEO.
Thank you so much for watching. On behalf of the director of the show, Calvin Kibet, please keep those conversations coming on social media. Share and subscribe to our YouTube channel. Leave us a comment on Facebook, West TV, Kitui Ohwasimiti OCKS on Facebook, at Mr. Kitui on X. Let's interact more. Let's talk more. This is CKS. Bye bye. See you next week on Tuesday.
Thank you.